So it's my great pleasure. To introduce Dr. Umberto Tachinardi, who is Professor of Clinical Medicine, Associate Dean of Health Informatics, and Interim Chair of Biomedical Informatics at the University of Cincinnati College of Medicine. I could spend the whole hour just telling stories about Umberto. I've known him for 30, we've known each other for 30 years, and became fast friends immediately when we met in the Sao Paulo airport. He started out in medical school, of course, and then did a fellowship at the Heart Institute of Sao Paulo University Medical School, where he became the CIO. He worked on ECG signal processing, telemedicine, and electronic health records. Now, that's just 30 years ago, 40 years ago. And then he became the state secretary, a CIO for the St. Paulo State Secretary of Health. Did I have that right, Umberto? And he's been CIO at a number of other places: University of Chicago, University of Wisconsin, Madison, and now he is at the University of Cincinnati College of Medicine. He's had a number of national posts, including co-chair of the Informatics Key Function Committee and the National CTSA Consortium, chair of the AMIA Clinical Research Informatics Work Group, and a number of other efforts. He's a clinical research informatician par excellence, and he's going to talk to us today about Skyline Vision, the silver lining in scaling healthcare AI without breaking the bank. So take it away, Umberto.
Thank you. Good morning, everyone. Thanks for being here. Thanks for having me. It's a pleasure to be speaking with you guys, and I'm going to start with some necessary conflicts and disclaimers. The usual. I just need to thank specifically Dr. Renata Mendoza and Dr. Rodrigo de Liberato that produced a couple of slides that I'm using here, and I thank them for that. So there is some background I wanted to share on what happened for me to be here. So I was in this conference in Boston. That was a few weeks ago, and Amy was there. We were chatting because we know each other for a while, and then she mentioned that there was an empty slot in the grid for this series. Probably a bigger fish bailed out and something, and she made a comment, and we were talking, and that was this date, so it's today, and she was thinking, what do I do? Should we cancel? And then she suggests that I could take that slot, and then I had to think, what do I do? The time is short. I could present something that I presented 100 times before, or prepare something new. So, the kind of doubt that we always have. And I told Amy, the one thing I really want to share with people is how uneasy it is these days to be sitting where I see it, and this AI avalanche of things happening. And the vendors think I have all the money in the world and the appetite to buy their stuff. And the people inside think I have all the money in the world and that they can ask whatever is available in this area. And most of that is all about AI, of course. And Amy is smart, and she immediately realized, oh, this is something we could use for the seminar. And so she got this fish, not a big fish, but, we had to figure out a title. And, we had to be creative, meaningful, and you can see we spent some time on that. And as two informaticians, what do? We brainstorm, preferably with alcohol, but that was early in the morning. So we had to use only, bare bones of brains. So that's how we do things. And all of a sudden, silver lining seemed to be an appropriate way to tackle this. So it's a problem, of course, but it's a good problem. In the end of the day, it's a good problem. It's a challenging problem. It's complex, etc. But it's so we shouldn't put a negative tone to the title. So decided to put the silver line. But then silver lining, Skyline, Cincinnati, you know, Skyline is a city staple. I don't like it, but you know, a lot of people do, and it's how we are known for. And then we started to figure out, you know, what do we put in the content, in the meat, and at the point, you know, the term bank became a thing because we were talking about resources, limited resources, and they look like a bank. We cannot break the bank. So I immediately remembered of the fact that the department there at UAB was primarily a bank. The building was a bank. So you can see the door of the safe here. And, you know, so that's Amy, that's Jim. And I said, okay, let's do it. We had a title, an idea of what to do. So what we do these days, we go to ChatGPT, and we generated 2 versions of what an abstract would look like. Actually, Amy did that with the seeds that I planted to her. And I tweaked it, and we got this abstract that you saw in the introduction. So that's why and how I got here. So let's have some fun. So a little bit more than a year ago, we had a newly appointed CEO on the UC Health System, which is one of my roles. I'm going to talk a little bit about that in a second. And Corey is his name. When Corey got there, he was asking all the VPs to come and present a vision of what to do in our different areas. And I decided to put this, I'm not presenting the whole slides, the whole set of slides here, but a few. So I said, I can't talk about technology. This is digital. They already label me as the tech guy or the IT, someone that will fix computers. So I decided let's put a different spin on that and say, I'm going to talk about enabling people to take better care of people. And that was the gist of this. And so in order to do that, we had to have a pervasive digital fabric that could help the humans, which is in the end what we were targeting at, to be more efficient on our end, and the patients to be receiving a better care and being happier about the type of care they were receiving. So what are the tools in our toolbox, my toolbox, and most of us here probably. So we have apps, systems, IT stuff, data analytics, decision support, etc. And all those pieces need to exist and be well-oiled and supported and sourced and things. So it's a lot. And I thought, well, I need to tell this new guy where we stand in those things, because that will help him understand where we should put the priorities on. So I developed this maturity level scale. And I pointed out that a few of our areas were in the keep lights on. The KLO is keep lights on. And so we were at low risk for the foundational stuff. We were quite okay on the data analytics, and you will understand why in a second. But in the more advanced area, algorithms, workflows, alerts, etc., the things that really help digital make a difference in the business, we were not great. We are still not great. So and the business domain areas are heterogeneous. There are a lot, different stakeholders, different necessities, different, and we also had to tackle the fact that we are an academic medical center. So just supporting the healthcare side is not enough. is great from the care side, but it's not enough because we still need to do education and training. So I told Corey, I feel my role here is to orchestrate those things. And that was the message here. And the result of that was that a few months later, I was more officially appointed as a senior VP at the UC Health side. And with that, my group became an integrated group of C-suite people that include the CRIO, I will spell out for those that are not used to those acronyms. So the Chief Research Information Officer, the Chief Health Information Director, our faculty, the Chief the Chief Digital, the Chief Data and Analytics Office, so many acronyms, the CIO. So we form now a platform that I call the DHS, the Digital Health Systems. And so they are mirrored in both sides, and they operate in this space between the College of Medicine and the UC Health. Is it perfect? Of course not. Is it efficient? Not so much yet, but it's a great start. This is the first time after so many interactions on my life that I can finally have a team that has the foot literally on both sides of the street. We are also connected to the CTSA, which is, in our case, very important to this talk, because the CTSA is a combination of the College of Medicine of the University of Cincinnati and the Cincinnati Children's Hospital. And despite the fact that the Children's Hospital is the Department of Pediatrics of the College of Medicine, there is no true connection between those two organizations. They are completely separate. The CTSA is the glue that connects the digital space for us in the research realm. So I am glad that my partner in life and a partner in the CTSA, we co-direct, Dr. Eneida Mendoza is the co-director with me on the CCTST Health Informatics Course. So we decided to put a frame on that includes the academic partnership, infrastructure and services, clinical research informatics, and some areas, thematic areas. So that's what constitutes the biomedical informatics core. And we connect to multiple pieces. Some of them were already mentioned, but a few you may not know, they are very local, like Digital Futures, Anderson Center. Those are institutes and centers that we connect through the CTSA. And the cool part of what we are trying to do here is we know we will not be able to put everything in one bucket. So we are developing this virtualized frame that allow us to route and triage requests and monitor and control requests that are coming from the CTSA front door. With that, we are gaining some interesting things. For instance, we had to elevate our data governance and stuff like that to allow people from one side to see data from another side and things like that. So those are interesting things, but they are still foundational. And this is not different than probably a setting that you have locally. This is the UC Health side. We have an Epic installation. We have a course of people that provide people with data, supporting developing models and stuff like that. And I will not go over that in detail today, but just to show, we don't do anything spectacularly great or innovative there. It's just, by the book. So, but our goal is to make sure that we can connect all those things that are in this area. And this digital ecosystem is becoming more complex every day. And that's one of the many reasons why this AI avalanche is happening. Because we know we are past the point of humans only taking care of this and making connections and supporting it. Oops. I don't know what I did. So in the meantime, we are dumping a number of things in people's lives, and people are burning out. They are stressed. We have an inefficient system, I would say. We need to do it much better. So there are insufficient, inefficient digital workflows. We have a lot of redundancy in our data systems, lack of interfacing, interoperability, poor ergonomics. We had a minimal capacity for proper developing testing. So I propose that we should tackle those four verticals. Improve our digital partnership with the university, with children's, etc. So we would have more hands on deck to help with that. We would develop this area of clinical informatics that was almost inexistent when I started. We had to orchestrate this whole digital ecosystem, and we had to elevate the data resources. You remember that I pointed out that we were poorly represented in this area. And that time, there was no, you can see I failed to mention AI. Because while ChatGPT was announced a few months before, it was not a thing yet in the radar. I had so many other priorities. So, but then, ChatGPT started to become a thing. And while you will see that ChatGPT is not AI, AI is much more than ChatGPT, there was this elephant, this disruption occurring, and we had to react. And you can see the impact in the area. In the first year, we had more than 1,000 papers published mentioning ChatGPT. That was the first year of the technology. And why was so much talk about that? So for one, the limitations that we have as humans in our ability, our cerebral ability to parse things is important when we are starting to integrate more data, more information, more knowledge on a logarithmic scale. And our brains are still limited in how much computing we can do at our brain. There is this work that shows that humans parse for maybe 5, a genius will go 8, 9 variables at a time. It's definitely not enough for what we are seeing now, where decisions per facts per decision go to the 1,000 level. We need not only computers, we need things in the computer that can produce insights that humans can digest and can act upon. We can see that the granularity of the data is growing. We have more of those variables coming, and those numbers are just proving that. This is a slide, a very commonly used slide by Dr. Friedman, that says that computers are not smarter than humans, or humans smarter than computers, but certainly the combination of humans and computers is bigger than humans alone. And that's what's happening, in my opinion, right now. AI is finally coming to is helping us get faster to the last mile, which is turning this huge amount of data that we are collecting today into something meaningful. And we are not doing great yet. Don't get me wrong. There is a lot to do in this area, but it's the beginning. We are starting to see where things can go. So you can see that this is an evolution of medicine along the centuries, etc. And I am highlighting, you know, few hundred years ago, we had only analog data available. The human brain was the only reasoning component of the system. It was all human. But now we go to some areas of care where we are all digital. We have big data, and we cannot do human only. We need people, and we need the machines coexisting and interfacing and interoperating. I also mentioned that I would say that ChatGPT is not AI, and AI is bigger than ChatGPT. So we tend to forget most times that AI is here for a long time. We are seeing the evolution of AI in the multiple domains of this discipline, growing, like image processing, like processing of real-time data in certain cases, maybe basic AI, not as sophisticated in terms of the language component, but certainly important. We have self-driven cars being driven not by large language models, but they use a lot of AI inside to decide where to turn, what speed to go, and things like that. And nothing of that is the same technology used by ChatGPT, but still AI. The same happens in our domain. I just wanted to highlight that because there is this impression, general impression that AI is ChatGPT or large language models. But why is this so so different now and so impactful? So there are many reasons for that, but I think personally that one of the things that I was really shocked was when, not shocked in terms of being completely surprised, but it's one of those times that you know this will happen, but when then it happens, it's like a surprise. So we are starting to see findings that using AI in our environment, for instance, may kind of replace a component that we are losing in our business, which is this human-to-human interaction. And amazingly, one of the ways to do that is by putting machines, AI, in the middle. So when chatbots can be perceived by patients as more empathetic than their caregivers, their human caregivers, and that's what some studies are finding. That's really something that should put us on pause and think, something different is coming to help us in this business. Because this communication with the patients is one of the many examples of things that are named by our clinicians as reasons for burnout, because they are getting overwhelmed with messages and stuff like that. And now we are seeing signs that AI, the proper AI, properly used, proper configured, etc., can be of great help. But it's not only there. We know a number of other areas like precision health, clinical trials can be supported with this array of data that we are bringing every day more. to help us do research and then improve our care. So, but there are also a number of challenges. We can see progress in a number of areas. Radiology is definitely one that is benefiting a lot from using those technologies. There are a number of opportunities like improving electronic health record systems to be more efficient. And I just pointed out as one of the many possibilities, which is those communications, offline or real-time communications with patients that can or not be supervised, and that's a completely separate discussion. I will not enter on that right now. But there is also things that would not be possible unless we have those components added to the solution, like precision medicine, for instance. We need the ability to sift through tons of pieces of data and identify the ones that are more meaningful to a case, to improve the diagnostics and the therapeutic plans for that particular person or particular disease. And those things require massive computing, a lot of smart algorithms to produce risk models and predictive models and identify patterns and stuff like that. So those are extremely important improvements that we have from AI. So AI is here, it's clear, but it's not a panacea. So we still need to do a lot to make AI better, but we shouldn't expect AI to replace everything we do. I gave, this slide was used in a different setting, a different seminar, and people ask me twice, so it's common question, is, are you saying that AI will replace functions and people? And not that I'm a guru of anything, but I would say maybe some people will be replaced in their current functions. I don't think that's about replacing people. I think this is about replacing or improving functions. And that's, what we do with people is a different story. When I started in this area, and Jim already mentioned that it's a long time ago, my mentor my main mentor, Dr. Candido Pinto de Mello, he used to say something that it took me a while to really grasp, which was, if you can be replaced by a computer, you should be. And I think that's still valid in the AI thing. We can do much better than what we can do with AI right now. So, but we still want to focus on those other things. So that's part of the challenge that I live every day. So do we replace people? When we calculate ROIs, for instance, it's always a question I hear from the CEO. Is this gonna allow us to reduce the amount of people needed to do this? And that it sounds a simple question. It's extremely loaded and extremely complex and difficult to answer. There is an expectation, but is that expectation what we want to do, or is that expectation what we don't want to do? So I will, you can read the rest here. It's important to remember again that AI comes in many flavors. ChatGPT and large language models is only one. But it's not only that. When you plug one of those things into your environment, you need to connect to connect and to do a number of things. You need to take into account your IT capabilities, your data environment, interoperability, personal capacity, ethics and fairness, safety and efficacy, regulations, etc. So you don't plug an AI component with some exceptions. Some are very specific to one machine or something. I'm not talking about those. I'm talking about things that will help clinicians, for instance, manage inbox, their inbox from patient messaging, or alerts, new alerts or old alerts, etc., or workflows, things that will affect bed selection, OR block releases, things that will affect the operations in general. And they will require, when installed, to be plugged into multiple databases, connect to multiple systems, etc. It's not easy. It's very complicated, and our teams are not ready yet for doing more than one at a time. And the question is one at a time enough? Of course not. We will need to learn how to do that hundreds at a time. And we barely know how to do one at a time. So I want to call out that complexity that may not be extremely visible to people. And that's in the implementation of something, an algorithm or a decision support tool. But remember that each one of those things had to be developed, had to be tested, validated, and deployed. And those things are kind of a cyclic. You develop a model. The model may work perfectly well day 0. It may not work perfectly well day 2 or day 3. And they may not work at all day 10. Others will work well the whole year, but it's always about how do we manage the life cycle of those things, because they are not static, they are dynamic in nature, and they are extremely dependent on the input data that they are receiving and how they are connected to other systems. So changes in the ecosystem change the performance of those models, and sitting where we sit, trying to orchestrate and manage those things need to be taken into account. How do we keep certification, validation, and appropriateness of those algorithms along the road? And more importantly, when they start to connect to each other, they become something different. Their performances and their reactions differ if they are in isolation or if they are connected to other ones. So that comes as a complexity. So how could we improve? I'm sorry, I'm not being able to read here. How could improper use of that? I'm not being able to read this. Jim, what is? I have a screen on my top line here.
Oh, yeah, the sharing thing, it's really annoying. You can move that around. It says, how could improper AI hurt patients and the healthcare system?
Thank you. So one of the things is when we take correlation as causation, which is not uncommon, unfortunately. Also, the difference between prediction and action. So poorly constructed, you can see the things here, but there is a strong need for us to have strict guidelines in developing those algorithms to take into account the rigor, the necessary rigor to produce things that are proper, that are scientifically and methodologically correct, and they are tested in the right way, they are calibrated, they are normalized, all those things. So, because we know in some cases we need to train models using noisy data, biased data, etc. I'm going to talk a little bit more about that. So that's something that usually concerns more to developers of AI, not so much on the healthcare setting. But there are things that we need to, when we introduce in the ecosystem, we need to recalibrate, etc. So the principles are important, independent of are we the authors or not of those models. So we need to know that those models can amplify and exacerbate those biases and those noises and those mistakes and those defects in the data. So I think relying on observational data will generally have an amplified effect on existing behavior. And our existing behaviors are not necessarily the best ones. So they will produce models that are carrying over and amplifying those defects. So what are the limitations and challenges with AI in biomedical research? Those are slides I borrowed from Dr. Deliberato. And so we tend to use the data that we accrue in our systems as a model for systems that will run not necessarily only here, but across the globe. And we can see that we have 75% of the population living in Asia and Africa, for instance. And the data that is available for training, that it comes, 40% of it comes from US. So it's kind of is that a model that can be used outside of US or not? It's a good challenge, because for a number of those models, this will be not the right training set for the data. And we know that this is even more critical when we are doing precision medicine and other things that based on genomics that are failing on diversity. So if we have databases that don't have the plurality of genomics that are necessary to reflect diversity, we will have biased algorithms and models out of that. So this is also happening with ChatGPT, because ChatGPT derives its knowledge or its ability to speak or to produce narratives based on what was available in the websites and the portals, etc. So we can see that when that is used in the clinical setting, it can and it is generating biases in gender and racial and both racial and gender biases. I would say probably other biases as well. So it's leading to inconsistent problems, and you can see this paper, for instance, that was assessment of racial and ethnic difference. It proves that people that were had their reads of their pulse oximeters that had darker skins would produce wrong PO2 information. So that data was skewed from the beginning. If you had a pool of people with those same sensors that would misread people with darker skins, that means the database that will train the model comes biased. So those are the kind of things we need to have a lot more attention to. Evolution of sepsis. So that's a good one. This is a model that is in place today in one of the predominant EHR system. It's offered as a predictive model for sepsis. This paper shows that the performance of this algorithm is no better than random. So why are we putting that? And once we put it, it will start to generate its own bias, because that's what the models do when they have an algorithm that will produce an action. It will start to change the pattern of the care, of the workflow, etc., that will then change the data that is being feeding the system. So how do we gauge the validity of those models? Because the vendor told everyone this is good, and now we are seeing some revision of the models showing it's not that good. So sitting where we sit, we are pressed to reduce sepsis, for instance, cases, because we don't want them. We want to predict them as early as possible so we can do something about it. It's very hard to do something later or impossible. So we crave for those models. And then a model come, what do? We put them on immediately in use. Do we test them? And how do we test them? We don't have good models for doing that yet. So the best we can do right now, in my opinion, is to increase the digital literacy more and more. We need everyone to understand better what is happening, what is working behind the scenes, not the details because it's too much, but we need to have our people understanding better what are the characteristics of those models, the algorithms, and why are they doing things, at least at a top level. There is a lot of discussion about making those algorithms more explainable and more transparent, so people can understand the why is the model coming to that result. And that's one area that we certainly need to do more. But once we have that, who's going to do that? Are we going to need another layer of people in teams like mine just to do that? That's a big and important question. Or should we have companies that will be providing that kind of expertise to the healthcare systems? There are a number of laws already in place. That's another thing. We always need to check all those boxes. Are they compliant, non-compliant? Are we doing something that is illegal? We shouldn't. So we need to force the vendors to help us in this area, and that comes by increasing explainability of those systems, making easier and more open to see what data was used to generate those models, how the algorithms were developed and validated, and how do the pieces of the AI system work together. There are other unintended consequences given us how certain models were trained. There is this article showing that Black patients tend to receive less offers of care because the algorithm is not considering them the right. They are disconsidering the differences of the Black population. Therefore, they are not receiving the care they should because the algorithms simply ignore the diseases or the acuity of the conditions of those people of color. There is also another area. So we are using AI, starting to use AI to improve our billing. This is one thing that costs a lot on healthcare, and this is a good use of AI. If you use good algorithms, making sure that you're billing correctly is fair game. But now we are seeing, and hopefully this will stop, but Cigna was using a counter AI to deny claims that they were receiving. So there was an AI trying to improve the approval rate of the claims. And then there was, on the payer side, an AI that is fighting back to deny those claims. We don't want those battles of AI, but I don't think they're avoidable, unfortunately. This is something we will, and they are already giving headache to everyone in this area. So what are the risks and the challenges? Data privacy and security, we need to always keep an eye on that. Bias and fairness. This is a summary of what I went through already. Lack of explainability, regulatory and ethical challenges, dependency on high quality data. So the better data you have on your training set, the better model you will get in the end. Risk of automation bias, intellectual property and plagiarism issues. I didn't have time to go over this one, but it's clear that this is a thing now that you see New York Times and others producers of content challenging the AI machines for using their content. Cost and accessibility. So everything adds to the cost. So remember, every time you plug one of those things, that's an extra cost of licensing, cost of maintenance, cost of support, cost of integration, cost of implementation, cost of training, cost of decommissioning it later. It's a chunk of things, and multiply that by thousands now. Technological limitations and failures. Not everything is working as we thought it would. Easier to generate fake data. And that's something, that's the criminal side. I will not even go in that direction. For people that are using a commercial system like Epic, which is our case, you can see a number of AI features that are available for us to activate. We are targeting at one of them right now in our environment, which is the ambient notes. And we have a number of features that could be turned on. They are not. You can see that they are not. And those are two, and I'm not saying they should not. It's just that the decision to turn each one of those switches on has a cost, require planning, requires strategy, and we need to be thoughtful about that, because just turning everything to the right may cause consequences that we are not prepared to have. You just saw the sepsis model was an example of something that was being sold as efficient, but it's not. So we need to be very careful. And this goes in the complexity. Remember when I mentioned the avalanche of AI things? This is one of those, and this is an internal avalanche, not even considering the external one. And the left is what's available now, and the right is more is coming, more is coming. And those are, same happens with features that will be facing the patients and also the finances. So AI is pervasive, it's ubiquitous, it's coming in both loads, and we need to learn how to do that right. And this is just a summary of some of the predictive models that are available. And this is just the very tip of the iceberg, because there are a number of companies selling add-ons to what you see here. And the EHR is not the only one. When you're playing the healthcare game, like we need to do, we have the back office tools that are adding more and more AI. We have the ERP tools, the enterprise resource planning tools like Oracle, Texas, in our case, could be SAP, any of the other systems that will help improve supply chain management, contracting, talent management, a number of the things that are currently road bottlenecks or hurdles, etc., can be eased by AI. But again, every one of those decisions, which are the right ones, when should we put them, how will they affect the ecosystem? They are the big challenge that it's part of my nightmare. So I will stop here. Thank you for listening for this haranguing here. I asked DALL-E, which is is part of the ChatGPT company, OpenAI, and I said, can you put a thank you slide, create a thank you slide for a lecture that will go over those topics, and this is what the DALL-E generated. So I'm not really a fan of it, but I wanted to share. So with that, I will stop. Thank you, and I think we have a few minutes for questions if you want. Dr. Semino.
First of all, let me thank you for an excellent talk, very stimulating, and very happy to have you contribute to our seminar series. So thank you for that. When you started your talk, you gave us a very clear explanation of how you developed the theme and the topic and the motivation. Do you think, or do you expect that we will get that kind of explanation from AI when it generates whatever it's generating? I mean, because if you ask ChatGPT, how did you generate this? I mean, you can ask it, but if you were to really build an explanatory module, I think it would say, well, given the previous 900 words, the most likely word I should say next is this word. And then given the previous 901 words, the next word I should say is this word. And so it's explaining how it generated the text. How that works, though, and how it weights things and that sort of thing becomes much more complicated. And you think about a neural network and say, hey, the neural network said X. Early AI like Mycin and QMR and DExplain, you could understand how they work because you could see what knowledge they were using to generate their answers. But now it seems more obscure, and I'm wondering what kind of explanations we can expect from this, 21st century AI.
Yeah, that's a tough question, but let me use one example here. When we started, so we are now, as you saw, in the process of selecting one of those solutions for ambient nodes because it was ranked very high in the priorities of our clinical folks in terms of a new feature to be added. And I was a little bit of a cynical when we started to select to line up the 2 or 3 that would present to us, and then came first demo, and I will not mention names here, but you can ask me offline if you want. But I saw the demo. I was so impressed by how efficient it was in doing what it was supposed to do. And what was it supposed to do? It was listening to a conversation between a caregiver, a pseudo caregiver, a fake, and a patient and a companion. And the actors were our people, not the company people. They were just talking over. And after 30 minutes of that talk, the thing came with the summary of the visit, all the ICD codes for billing, That was, I knew things like that were possible, but when you see that thing happening in front of you today, it's scary. It's scary on the positive tone. Don't get me wrong. Can I explain what happened there? Of course not. But I had a few, I know a few things, and you know the same and maybe more than I do. One thing is to have the speech to the digitization of the conversation, and it could have AI on it or not. It could be a rule-based thing. It doesn't matter. At some point, it would become digital words as opposed to analog words. So that part of the process, can you explain what you listen? Yeah, they could, because you can go back to the recording and actually replay the audio. So for that part, it's okay. And then it generates a summary. And that's where the LLM example, which you just alluded to, happens. Because now there is a lot of blurb that was the conversation. And now the machine needs to get things that make sense there and put in phrases and sentences that are understandable, that are meaningful. And that's the part that follows the training of the model. And obviously, they use clinical notes, hundreds of thousands of clinical notes to train those models. So they have a sense of what to take out of a recording of language. So at one point, the language model is only producing something in English. On the other side, part of that comes from the training in the clinical language that allows it to know what are the 900 words that are more meaningful to that particular summary, because it read millions of summaries. I don't know, whatever was used to train the model. So it's a pipeline, and that's what I'm trying to say. It's not only explaining how the algorithm, the ChatGPT works, because ChatGPT is also a pipeline. It has many components. It needs to understand what you're asking the machine, right? And that's different than the part of the mechanisms that will generate the output for your question. So I think it's hard to have an explanation of every piece of that pipeline, but it's important that you have explanation for the ones that will matter to the actionable components of that process. And even if they are not easy to follow, like because they are not linear, and you just said, even the GPT thing cannot know what will be the word 901 before it decides what is word 900, right? So it can predict what is 901 only after 900 is defined, is selected.
Right.
So, but what will define the odds that 901 is a word that is correct for a summary of a visit of a patient is how well trained the model was in its training set. And that's where the things I spoke about, the biases in the data, etc., they play a big chunk. So that's my only concern, is that if the training set was unaware of the differences of different people that we have to care about, the summaries may exclude things for Black people, for instance, that should not be excluded. They are important.
Thank you. Okay. Maybe we have time for one more question.
Yeah, we are at time. So I don't know if Umberto, you're able to stay a little bit longer, or do you need to go?
I can stay a few minutes more.
Okay, and thank you everybody else who's also has stayed, and don't feel obligated to stay if you have somewhere else you need to go. Any other, thanks for a very great presentation. And I didn't think you were going to go over in such detail how the sausage was made, but yeah, made for a good story. I'll have to be careful what I say around you next time. Anybody else have any comments or questions, either from the Zoom or also from people attending in Shelby 105? I have a question, and Jim knows I like to ask hard questions. So, just to be warned, you know, the first slide where you mentioned some of the things that need to be addressed, some of the things, the high priority areas that need to be addressed, like, you know, better training and another layer perhaps between the clinicians and the ones asking, getting the algorithms or getting the decisions, and some of those, you know, they sound like really hard things to do, like the you know, infrastructure, training, workflow, business, you know, practices, how things are done, regulations, all those things. You know, those things all sound like things that take a long time, a lot of time and energy, and a lot of money. So I was thinking about the bank vault. And also they're things that are very long term. They're important, but people might not see them as urgent. And if there isn't some kind of will, political or financial, to make those things happen, you know, it just may not happen. So, you know, partly like, what do you think will happen, just looking into the crystal ball, which we don't have, unfortunately. And also, how can we get to where we need to be on those things? Because right now that seems really far away. You talk about burnout, people just trying to break even and, you know, deal with patient workload and such. So what would you say to that? Ask ChatGPT. No.
Yeah. That's one thing I would not ask ChatGPT. I can use ChatGPT for a number of things. I would not ask that question yet to ChatGPT. The reason is, I don't think there is an answer based on the past. that could guide us in the future. I think we're seeing a different challenge. While interoperability was a problem before, I mean, the complexity of interoperability was an issue before. Now with AI, that complexity moved to another level. So I don't have a good answer to you, except we will need to make some mistakes in how we prioritize, how we implement, how we select, et cetera. And what I'm doing internally is that I'm picking few things right now that we can have more control over the cycle. Even if we screw up, it's one thing, and then we can figure out and learn from that process. I know this is not enough to keep us to keep the pace, because we are saying no to 99%. The moment you're starting with 1%, it means I'm making 99% of the people that are asking for those things unhappy because they are put on hold. But there is so much we can tackle right now, and I hope we will start to accelerate by learning. And the more those people are educated, they will also come with more educated recommendations, suggestions, or requests. That's my hope, at least. Our team, being more educated, will also learn how to validate, test, figure out faster. That will also allow me to scale the number of those solutions. I'm counting on our ability to learn fast. That's probably the best answer I can give you right now. We need to pay attention. We need to eat our own dog food, because we need to be a learning, decision-making member of this thing, or we will fail.
Yeah, well, it was good to see some of those features embedded into your EHR system, and also the fact that you had the ability to turn it on and off, when you want to see whether it makes sense for you. And even if they're not that good, I'm glad that at least they're trying. So at least things are getting out in front of people. I don't want to rely on the vendor to be doing that. All right, any final questions, comments? I know some people have stuck around. I know that. Thank you, everybody, for staying around.
Yep.
Want to have everybody.
Well,
all right.
Thanks again, Umberto. All right, take care.
Yeah, thank you very much. Hope to see you at the next one, and happy eclipse viewing if you're going to be going to see the eclipse.
All right.
Bye.
Bye-bye.